Thank you. I'd like to acknowledge my co-authors as well as people that I talk to from time to time. So in the central tremor treatment, of course, we are getting a single scan plane and multiple scan planes. And first we go through the alignment phase where we have a small temperature rise. And what I'm going to do is I'm going to plot this third time point right here down on this plot, which is the temperature at the third time point as a function of power. After the alignment phase, then we go into the location verification phase where we're looking for those reversible symptoms to be modified. And I'll use a slightly longer duration sonication, but I'm still going to plot that third time point down here. So again, it's the temperature versus power, and what we've seen is that we've been increasing. And then lastly is the treatment phase where we're really trying to increase the power to get a high temperature rise, and we like to get to about 60 degrees. But what we see when and we can get up there with a longer duration, but what's interesting is we take that third time point and then plot it down here on our curve, and what we see is that the temperature is increasing through those first two phases, and at some point in some patients what we see is there's this inflection point and there's a decrease in the temperature that's been achieved as a function of power. So we know that this is our scan plane, this is our lesion, that if the transducer is up here, that we're going to have a change in the acoustic parameters and we're going to have increased absorption. And so what we're going to see now is that there's going to be increased absorption at the front edge, and it's going to sort of shield the ultrasound from getting to the back of the focal spot. So what we're going to see is potentially a focal spot movement away from the thermometry scan plane. So the purpose here was to investigate this focal spot movement away from the thermometry scan plane as an explanation for the lower than expected temperature rise. So my methods are shown here. I looked at 14 patient treatments. These were all treatments that we were targeting in the ACPC plane. On the temperature images, I plotted that third time point as a function of power. I found the inflection point, and I counted the number of sonications after the inflection. On our immediate post-treatment T2s, I took the sagittal scan plane and found the zone 2 and segmented zone 2, thresholded so that it was very easy to find the top edge of the zone 2 and measure to the ACPC plane as well as the bottom edge of zone 2 to the ACPC plane. So my results are shown here. So over here we see is the distance from the ACPC plane. In blue is to the top of the lesion, and in green is to the bottom of the lesion. Now this is one pair of data points per patient. So for example, this pair is for one patient, and there's each patient is one point here in the number on this axis. So what we see here is if we look at the distance in the ACPC plane, it's increasing as we increase the number of sonications after inflection. But at the same time, the bottom edge is relatively constant with respect to the ACPC plane. Okay, so when we look at the hand tremor improvement, we see that's increasing as the distance to the top edges is increasing as well. Now this is something that's relatively well known in the literature. And what's interesting here is that we see an improvement as we have more sonications after inflection, but what we can't tease out from this data is the change in the position versus the fact that we've really changed the tissue parameters. So this data is consistent with the lesion moving towards the transducer from the target. This is sort of depicted as if the lesion is straight up and down in an axial scan plane, but in fact the lesion is double oblique. So at the EuroFUS meeting I reported that looking back at our lesions that almost all of them were double oblique, where the superior edge is posterior and medial. So what that means is that we can't just look at other scan planes in order to get a good picture of the lesion. So this is a different patient now showing you that in the axial scan plane, again, we're seeing that third time point as a function of power, that the temperature is rising at that third time point, and then it starts to plateau, so that's our inflection point. And the same thing happens in the coronal scan plane as well. So it's very likely that the lesion is moving out of all of our monitored scan planes. So in conclusion, the data is consistent with the lesion moving towards the transducer from the target. The implications for clinical treatments are, it's important to understand this so that you understand the ability to target where you want to, how you order your sonications, just like with fibroid treatments, for example, we probably want to go far away from the transducer and then come closer. And then also for understanding what the thermometry is telling you. Of course, there's implications for simulation. If you want to simulate the treatment and the temperature rise, you probably don't want to use the data at the end of the treatment where after this has happened. And of course, what this really is doing is underscoring the need for volumetric thermometry. Of course, we've already seen a couple of talks of volumetric thermometry. There's lots of ways to do it. There's a total of 3 talks, I think, at this meeting. This is just some work from our own that we're not presenting here, but just shows that you can cover the whole brain in about the same time frame as we get a single slice right now. And not only that, but have lower standard deviation in the temperature maps than with our current images. So thank you very much for your attention, and I'd just like to acknowledge my grant support.
Questions? Jeff?
That was a great talk. So you seem to say that the focal spot is moving, or you said the lesion is moving. I mean, do you think that it's just that the tissue's ablated where you're measuring it, and that the only part that you're able to measure the heat is around the ablated area? Like, for instance, I guess protons relax differently in non-viable versus viable tissue.
So the acoustic parameter, the absorption will increase once you ablate it, and so the temperature actually should go up instead of down. So So I think that potentially answers it.
So when you treat GPI, the axis of the lesion of the temperature looks like it's moving up toward the internal capsule in that axis. It's almost an axis that's at right angles to what you would expect from deep brain stimulation. So it sort of seems to be migrating upward and medially. And is this the explanation, or is it something about the tissue itself?
So are you saying that the temperature rise is migrating and
yeah,
the
when you
lesion
look at
is
the temperature maps,
yeah.
they elongate
yeah.
and they're tilted. So they're tilted toward the internal capsule.
Okay, so the shape of the focal spot and the fact that it's tilted is a different thing. So that has to do with whether how the ultrasound's applied in the skull, and whether there's inflections in basically what your effective aperture is as you're hitting the focal spot.
So it appears to be moving up and in, but maybe it's...
So the shape of the focal spot is different from sort of the lesion moving as you keep on sonicating. Yeah. So what I was saying is that typically with essential tremor, we'll start out with a focal spot which is sort of a nice oval, but then it's a stubble oblique. And then as we keep sonicating, it's going to move in that direction towards the effective aperture.
Other questions? Sorry.
Hi, very nice talk. Do you think it might be possible it's because the skull is getting warmer, heating, so you have a change of speed of the sound in the skull, and that is causing that the focal point start to get closer to the transducer?
It's entirely possible that the acoustic parameters of the skull are changing, and if we haven't changed our phase aberration correction, then that could change the focal spot. I don't think it changes the results that there's a lower temperature rise and that the focal spot's moving, but the cause of it could be that the acoustic parameters are increasing at our focal spot, that the absorption is increasing there. It could potentially be what you're suggesting, but I don't know how big that effect would be.
Thank you.
One more question. Have you tried to compensate for that, shifting the thermometry plane to where you expect the focus to be?
No, we're not allowed to do that.
Okay.
One other option is, can you just do an oblique scan plane? Mm-hmm. And we're not allowed to do that either. So we really need 3D thermometry.
That's right.
Yeah, okay.
Thank you. Thank you.